Pityriasis Rosea, an engaging exploration for dermatologists. Welcome, esteemed colleagues. Today, we're delving into the fascinating world of Pityriasis Rosea, a common yet intriguing skin disorder that often presents both classic and perplexing clinical scenarios. Predominantly affecting healthy adolescents and young adults, this acute, self-limiting papulosquamous condition is notable not just for its distinctive features but also for the mysteries that still surround its cause. Imagine a patient walks into your clinic with a peculiar rash that seems both familiar and enigmatic. While the classic presentation might lead you swiftly to a diagnosis, atypical variants can challenge even the most seasoned dermatologists. And although a viral etiology has been a long-standing hypothesis, definitive evidence remains just out of reach, adding another layer of intrigue to this condition. History. Let's journey back to the roots of Pityriasis Rosea, 1798. Robert Willan, a pioneer in dermatology, first described a condition he called Rosea annulata, observing a self-limited eruption in healthy children. 1860. Camille Melchior Guibert, a French physician, introduced the term Pityriasis Rosea. Derived from the Greek words pityriasis, meaning scaly, and rosea, meaning pink, the name beautifully captures the clinical essence of the disease, a pink scaly rash. Isn't it fascinating how historical observations continue to shape our modern understanding? Epidemiology. So, who does Pityriasis Rosea choose as its host? Age of onset. It predominantly strikes individuals between 10 and 35 years of age. Cases before the age of 2 are rare, making it a condition of the young and active. Gender and race. There's a slight female predominance, but no racial predilection. Pityriasis Rosea is an equal opportunity visitor, occurring worldwide. Duration. Typically, it graces patients with its presence for about 6 to 8 weeks, but on rare occasions, it can linger for 5 months or more. Seasonal variation. Interestingly, modest peaks are reported in the spring and fall, and in some regions, during the rainy season. Could environmental factors be playing a subtle role? Pathogenesis. Now, let's venture into the realm of the unknown, the cause. Etiology. The precise cause of Pityriasis Rosea remains unknown. This uncertainty fuels both research and curiosity. Viral etiology hypothesis. Human herpes virus 7, HHV7, is the prime suspect, with HHV6 also in the lineup. However, the evidence is conflicting. Some studies show no significant difference in HHV6 or HHV7 DNA between patients and controls, casting doubt on their role. Other viruses like HHV8, H1N1 influenza virus, and even SARS-CoV-2 have been implicated in isolated reports, supporting evidence for a viral cause. Prodromal symptoms. Some patients experience mild symptoms before the rash appears, hinting at an infectious process. Clustering of cases. Occasional outbreaks suggest a contagious element. Rarity of recurrences. The fact that Pityriasis Rosea rarely strikes the same person twice implies lasting immunity after the initial episode. Classification. It's considered a parviral exanthem, a skin eruption associated with a viral infection or reactivation, but without direct viral identification in lesions. This adds to the enigma, doesn't it? Clinical features. Let's bring the clinical picture into sharp focus. Classic presentation. Herald Patch. The story often begins with a single lesion called the Herald Patch, an early messenger of what's to come. Location. Typically appears on the trunk, but may also show up on the neck or proximal extremities. Timing. Predates the generalized eruption by hours to days and is seen in over 50% of cases. Characteristics. Color. A delicate pink to salmon or pink-brown hue. Size. Usually 2 to 4 centimeters, but can range from a modest 1 centimeter to a larger 10 centimeters. Appearance. Slightly raised, advancing margin. Central fine scaling with a collarette of scale, a trailing scale with the free edge pointing inward. A hallmark feature. Prodromal symptoms. Some patients might report mild headache, fever, arthralgias, or a general feeling of malaise. Generalized eruption. Timing. A few days after the Herald Patch makes its debut, multiple lesions begin to appear. Distribution. Lesions spread over the trunk and proximal extremities. Notably, the face, palms, and soles are usually spared. Lesion characteristics. Shape. Round to oval papules and plaques. Alignment. Their long axis aligns along Langer's lines, the natural skin tension lines. Pattern. On the back, this alignment creates the distinctive fir tree or Christmas tree pattern. Color and scaling. Similar to the Herald Patch, featuring central fine scaling with a collarette of scale. In darker skin, lesions may be more papular, folliculocentric, and hyperpigmented, showcasing the condition's versatility. Duration and symptoms. The eruption generally persists for 6 to 8 weeks before resolving spontaneously. While often asymptomatic, some patients experience pruritus ranging from mild to severe, which can be quite bothersome. Atypical variants Pityriasis Rosea isn't always textbook, and that's where our diagnostic skills are tested. Inverse Pityriasis Rosea. Distribution. Lesions predominantly affect the axillae, inguinal areas, and face. Pathology. When we look under the microscope, Pityriasis rosea reveals subtle but telling signs. Epidermis, mild spongiosis, intercellular edema between keratinocytes, elongation of reedy ridges, parakeratosis in small mounds, indicating retained nuclei in the stratum corneum, dermis, enlarged dermal papillae, superficial perivascular infiltrate composed of lymphocytes and histiocytes, mild erythrocyte extravasation with intraepidermal erythrocytes, severe cases, pronounced features, with possible intraepidermal pustules, biopsy, often unnecessary due to the characteristic clinical presentation. When in doubt, histology can help rule out other conditions. Differential diagnosis. Differentiating Pityriasis rosea from its clinical mimics is crucial to avoid misdiagnosis. Secondary syphilis, similarities. Both can present with a papulosquamous eruption. Distinguishing features. Look for split papules, condyloma lata, and mucus patches, sexual exposure history and signs of a primary chancre. Systemic symptoms, more pronounced in syphilis, often with lymphadenopathy. Histology, presence of plasma cells is suggestive. Serologic testing, positive syphilis. Serology confirms the diagnosis. Drug-induced Pityriasis rosea-like eruptions may have a slower resolution than idiopathic Pityriasis rosea. Tinea corporis and tinea versicolor. Fungal elements on KOH examination. Nummular dermatitis. Coin-shaped eczematous plaques. Guttate psoriasis. Smaller papules with a thicker scale. Pityriasis lichenoides. Consider when lesions persist beyond 4 months. Treatment. Most patients will be relieved to hear that Pityriasis rosea is self-limiting, but symptom management can enhance their comfort. General approach. Patient education and reassurance. Explain the benign nature and typical course. Set expectations for resolution within 6 to 8 weeks. Symptomatic management. Pruritus relief. Topical therapies. Counterritant antipyretic lotions like menthol or calamine. Low to medium potency corticosteroids to reduce inflammation. Oral antihistamines, helpful for nighttime itching and improving sleep. Phototherapy, UVB phototherapy, both broadband and narrowband UVB can expedite resolution. Natural sunlight, moderate exposure may have beneficial effects. Systemic treatments, corticosteroids. A short course of systemic corticosteroids might be considered in severe cases, although used sparingly due to potential side effects. Antiviral therapy, oral acyclovir, some studies indicate it leads to good or excellent improvement. The exact mechanism is unclear, but it may be worth considering. Antibiotics, oral erythromycin, reported to decrease pruritus in some cases. Efficacy is not well established and may not be first line. Special considerations in pregnancy, potential risks. There is a possible association between Pityriasis rosea and spontaneous abortion, particularly during the first 15 weeks of gestation, linked to active HHV6 infection. Management, careful monitoring, regular follow-ups to monitor fetal well-being, multidisciplinary approach. Collaboration between dermatologists and obstetricians is crucial. Conclusion: Pityriasis rosea offers a rich tapestry of clinical features that are both classic and atypical, challenging us to stay sharp in our diagnostic skills. Its self-limiting nature is reassuring, but understanding the nuances of its presentation and management ensures we provide the best care. As we continue to explore its mysterious etiology, perhaps future research will unveil the secrets behind this intriguing condition. Until then, let's remain attentive to its patterns, educate our patients, and appreciate the complexities that make dermatology such a fascinating field. Thank you for your attention. Are there any questions or experiences you'd like to share regarding Pityriasis rosea?